First case, 70-year-old man with multiple left colon ulcers, abdominal pain, and hematochezia. Lamina propria, focally hemorrhagic. Hyaline changes of the lamina propria, focal superficial ulceration. Mild atypia with occasional mitotic figures in deeper glands. Diagnosis: Ischemic colitis with reactive atypia. Next case, 55-year-old man with monoclonal gammopathy and lytic bone lesions. Relatively anaplastic cells and multiple spherical cytoplasmic and pseudonuclear inclusions. Dutcher bodies. The diagnosis is anaplastic myeloma. Next case, 45-year-old woman with multicentric pigmented plaques in vulva. Basaloid proliferation of atypical cells. Diagnosis is VIN3 or high-grade squamous intraepithelial lesion. What type? With P16, we confirm 100% nuclear and cytoplasmic positivity of the cells. So the diagnosis is dedifferentiated type VIN3 or high-grade squamous intraepithelial lesion. Do not confuse with the usual type that is more related with P53 mutation, more solitary lesions and nothing to do with HPV lesions. Next case, 1 centimeter well circumscribed tonsil mass in 60-year-old woman. Low power, high powers on microcyst, mucocytes. Musicarmin is positive, cytokeratin positive, calponin CD117 negative, cytokeratin 7 positive, cytokeratin 20 negative, Ki67 low proliferation rate, SOX10 and DOC1 negative, GATA3 and mammoglobin negative. So we know that it's not a secretory mammary analog carcinoma. We know that it's not with SOX10 and DOC1. We know that it's not adenoid cystic with DOC1 negative. We know that it's not actinic cell carcinoma. So the diagnosis is low-grade mucoepidermoid carcinoma. We confirm with positive intermediate cells positive for P63. Next case is a 55-year-old man with common bile duct lesion, obstructive. It's a polypoid lesion with complex papillary proliferation, some micropapillary structures with this cribiform appearance. Not definite evidence of invasion. The diagnosis is papillary neoplasm of common bile duct with high-grade dysplasia / carcinoma in situ with no evidence of invasion in the biopsy. I think it's more an intraductal papillary neoplasm of the pancreatobiliary type, not really the intestinal type adenoma. The last case, woman with in the 50s with a small round patch of alopecia in the scalp, telogenic valves with swarm of lymphocyte like swarm of bees around. This is a very classic entity and the diagnosis is alopecia areata.